Good day, everyone. And my name is Milan Simoneau. I am the Women's Wellness Coordinator at the PSP headquarters. And on behalf of our team, I am pleased to welcome you to today's Ask a Doctor webinar. This is our third session here with Dr. Hansen, and in today's session is titled Menopause in the Workplace. Please note that this session is being recorded and will be available for viewing on our website after the event. For your privacy, your camera and microphones have been disabled throughout the webinar. If you have questions or comments, you may submit them at any time using the MS Teams Q&A feature. While we will do our best to address as many questions as possible, we may not be able to answer all of them today, or maybe we have answered them in the previous sessions. So we encourage you to go back and watch the previous sessions on our website. If you wish to listen to this session in another language, you may use the Wordly link or the QR code provided to access translation options. Today's presentation is intended for educational purposes only and does not replace the advice of a qualified healthcare professional. If you have personal or specific health concerns, we encourage you to speak with your healthcare provider. So without further ado, it is my pleasure to introduce our speaker, Dr. Catherine Hansen, a Canadian-trained and U.S. board-certified obstetrician, gynecologist, a menopause practitioner, and health advocate. Dr. Hansen, thank you for being here with us today, and over to you.
My absolute pleasure. I am really looking forward to unpacking this topic, menopause in the workplace. And my co-collaborator, Dr. McCall, has given this presentation in French. I want to thank her for all of the support with preparing this presentation. Dr. McCall and I have a couple of disclosures noted here on the slide, nothing that is relevant to what we'll be discussing today. And a land acknowledgement. This land is the traditional and ancestral territories of countless Indigenous nations. We acknowledge that we are guests on this land and pay our respects to elders past and present. Menopause, specifically in Indigenous women in Canada, remains understudied, and colonization impacts the way menopause is experienced among Indigenous peoples. You've heard the medical disclosure already. And we want to ensure that everyone understands and feels included. Each person's experience of menopause is unique. People who are transgender, non-binary, or intersex may also experience menopause, and more research is needed to understand the impact of menopause on women and diverse communities. So the objectives today, and what I'm really excited to unpack with you, is to describe perimenopause and menopause, why it matters in the workplace, to recognize menopause at work and how it impacts Canadian women and globally, and men and women as well, identify practical supports for professional women and specifically military members, to know where to find Canadian resources and also to know when to seek medical care. Let's start with setting some context. Menopause is an occupational health issue requiring systemic solutions. So though it may feel like you're in this alone, it's not an individual woman's problem alone to solve. Creating menopause supportive workplaces benefit employees, employers, organizational outcomes in so many ways. And we'll talk about a lot of that today. Let's go through menopause in review, because in order to understand menopause at work, it's important to understand menopause generally. And there are other presentations given on perimenopause and menopause for you to review. Menopause is an experience that every woman will go through. It's usually defined as the final menstrual period. So there's 12 months of no menstrual bleeding, and then the final menstrual period. It's like the anniversary of your last period. It could be surgical or medical at different time frames. Chemotherapy, POI means premature ovarian insufficiency, which is a medical diagnosis that leads to early premature menopause. And then perimenopause can occur for 5, 7, even up to 10 years. So if you're late 30s, early 40s, and you're starting to experience symptoms that are vague or hard to understand, or your cycles are becoming irregular, that could be the onset of perimenopause. And I always like to show this slide because it gives us the actual sort of scientific understanding of menopause and what is actually occurring. So there's, if you look at the top, the final menstrual period is outlined by that red arrow. And early menopause can start several years, like we said, even up to 7 or 10 years prior to that final menstrual period, when menstrual cycles, and I know you can see my cursor here, menstrual cycles start to get irregular, and then they get even further and farther between. There's some blood level changes and plenty of symptoms that start to take place. And then that final menstrual period starts the onset of early and then late postmenopause. So we use the word postmenopause and menopause almost uh, together. Sometimes people say I'm in menopause. Some people say I'm postmenopause. It means exactly the same thing. But what's relevant for our conversation today is that as estrogen starts to decline, as ovaries start to become less effective, these symptoms start to happen. And this is what we would consider the symptomatic time frame if people are having symptoms. And throughout that entire time frame, when symptoms are up and down and variable, a woman is in her professional years. So that is why menopause is such an important topic for us to be talking about with respect to work. Why does this matter? There's lots of information coming out for Canada specifically, and we had a question that came in advance regarding who are the top researchers in Canada. And I had already put this slide together, so this gives you an idea of some of that. And at the end, we'll go back through some resources. But there's some great work coming out of University of British Columbia, some great work coming out of Toronto, Sinai Health. And a lot of the universities are starting to now do research. If you're looking for, if the question was specific to research, which it seemed to be, a lot of those university centers are doing research on menopause. And we've also got some great work at University of Alberta. I'll dig back into some other resources for you at the end. And a group that I work with also from the University of Alberta is associated with the Society of Obstetrician and Gynecologist Guidelines. So if you're looking for the peak of information in Canada, you're going to go to the SOGC, or the Society of Obstetricians and Gynecologists of Canada. But I thought that was a very informed question. Who are the lead researchers and where are we getting our information? This is just 3 of the papers that I will unpack in this talk. And again, sharing a lot more about where you can get more information. We know that menopausal symptoms can impact many things. We've talked about this already: sleep, cognition or brain fog, mood, irritability, even depression, energy and recovery, musculoskeletal pain. Some people feel like that is an onset, and it didn't used to be associated with menopause, but we're noticing that it is, and we're acknowledging that it is. So some of those vague symptoms that people couldn't explain, we now say, you know what, we think this is related to lack of estrogen. Performance may be impacted, productivity, and I put fulfillment or quality of life on there myself, because that is ultimately what we want to be focused on when we're talking about our workforce. We're not just talking about getting every drop of productivity out of people, but actually fulfillment and meaning at work. The reality in Canada is that 5 million working women are over the age of 40. A fifth consider leaving their jobs. 43% take time off. 72% report poor concentration. 67% report poor confidence due to symptoms. They're feeling shaken in their work environment. The unmanaged symptoms of menopause cost the Canadian economy $3.5 billion annually. And that is absolutely preventable, and a huge gap in what we are able to do from a country perspective. We know that there's, in addition to the numbers you see on the slide, $240 million in lost productivity, 540,000, or about 500,000 days lost, 500,000 days lost due to menopause. A lot of women hide their symptoms. They're not comfortable talking about their symptoms. And this isn't just Canada, obviously. Women 50 plus are the fastest growing demographic and make obviously an essential contribution to the workforce, enabling women to work to their potential, which is my absolute passion and the reason I do this work. We want women working to their potential because women can impact not just global economy and output, but women are the heart and soul of our families, of our communities, of our workforce. It can be put in dollars and cents, as we've seen here, but it really can't be put into dollars and cents. We know that women are the heart. They're the rock and the foundation of everyone they touch. And so having women working and living to their fullest potential is ultimately the goal that we should all be aspiring to achieve, both in our own workplaces and in the places and the people that we lead. And the average age of menopause being 52 is affecting half the world's population, and symptoms can last a decade or longer. So this is a huge portion of professional career time frame. Isolation is leading to silence and stigma. Only 31% feel comfortable talking to their supervisors. Other things people are noticing, this is from the Menopause Society's consensus recommendations for women at work, for menopause at work, is that workspaces are crowded. People have trouble moving around. They're frustrated with the restroom situation. And get this, stress triggers symptoms. 100% of women reporting that stress triggers their symptoms. So that actually says a lot for how we can potentially mitigate symptoms by mitigating stress or by providing less stressful work environments. Coming direct from occupational medicine studies, this is symptoms affecting employees more than 50% of the time. So it's not just the proportion of employees, but it's how often those employees are impacted by these symptoms. These are symptoms that are common, so not just a few people. Fatigue, difficulty sleeping, poor concentration, poor memory, work performance, and having to take sick leave. These are actual occupational hazards. And menopause is a normal transition. So it's not a medical diagnosis. It's not niche. It is biological reality, and it's a reality for a huge portion of our Canadian workforce. And we're going to unpack some military specific information here as well. So how do we get around to solving this? How do we provide some solutions? I'm going to start with, what are the goals for those solutions? We want to support the individual and we want to support the organization. So in order to support the individual, we need to think of this as, how do we ensure not just performance, but safety and function? And again, I bring in quality of life. I think it's really vital for us to realize that women, men, everyone, we don't just want to feel like we are intended to perform all the time, that we are an economic entity to be leveraged. It's so important that quality of life continues to be front of mind as a goal. And to support organizational objectives, efficiency and productivity are important. And if you think about yourself, doesn't it feel better? So better quality, better meaning, better sense of purpose when you are feeling productive toward the tasks that are intended as part of your work. We want to avoid presenteeism, people just showing up and going home and just doing what they need to do, but not really contributing to their highest or not really enjoying. Absenteeism, so people taking time off because of menopausal symptoms or symptoms related, or lack of support. And recruitment and retention. So we're hearing a lot these days about recruitment and retention. We know that when we can't recruit the top talent, or we lose people after training them, that is a huge hit economically as well as personally for people. So I really think this quote is important for us to look at. Recruitment and retention are not theoretical. So they're not just words that people are putting on their reports. We know that symptoms without support actually change career trajectories. People actually choose what they do or what they don't do based on the support that they receive within their organizational structure. So let's talk about solutions for individuals? I think it's really important for individuals, if you're in this age range with me or you work with people who are, to understand that there are a lot of stressors at midlife that weren't previously front of mind. And we're human, so we need to acknowledge that these things are happening and that they're happening to a lot of us, especially in this age range. So aging is starting to come in, loss of fertility. Many perimenopausal women were hoping to have another child, and that is a very big stressor that may be something that a woman is dealing with in these 40 plus years age range. Sleep problems, we've talked about medical problems. You know, as we age, we start to have more medical problems, actual medical diagnoses that require treatment. Divorce and widowhood are much more common in this age range. Empty nest. So not only do we have ailing parents and elders to look after, we also have children, teens, college age, young adults. We're that sandwich generation, and career issues. So these are confounders that contribute to menopause. And as you saw with one of the studies I just presented, 100% of people say that their symptoms are exacerbated by stress. And these are common stressors for people in this age range. So what can we do as individuals, and we're talking about at work, what can we do to support our colleagues? We can talk about tracking patterns. You know, if sleep is not going well, or you're feeling hot or cold, what's your mood doing? What's your recovery like? What are your cycle changes like? What is happening to your body? Understanding the physiology that is happening to you, and then looking around and understanding that this is also potentially happening to other people around you. Prioritizing sleep protection. We've talked a lot about sleep in the other webinars. Sleep is paramount. If you sink your effort and energy into one modality, I would I would propose you start with sleep, because it actually ripples into everything else. You have a good sleep, you feel great. You have a bad sleep, everything else throughout the rest of your day really suffers. We know that, and it's not easy. Sleep is something that needs intentional effort. Reducing self-blame. This is not your fault. This is not something you've caused. This is something 50% of the population are going to go through. Mindfulness strategies are really important. So I had a question come in advance, and it was, what can I do about crying all the time, and not being able to stop and not knowing why, about my mood swings, even panic attacks? What can I do about the fact that I feel sort of out of control from a mood perspective? I feel irritable and I'm crying and I'm all over the place. And I want to raise this question that came in because it is one that I hear a lot. And I would encourage a few things, and each person is different and each person needs a different conversation, but generally, hopefully this is helpful. Um, Life needs to slow down. And if we are finding ourselves crying or fitful or panicky, or our nervous system is dysregulated, it is often related to multiple stressors, and overwhelm, by definition, is trying to do more than we have support or capacity to do. And so I invite this person, and so many other women I have spoken to who are having the mood fluctuations, to really get to the root. I love this time of life for women because it is a chance to slow down, to take stock, to really get to the root of why. You know, if you're crying, yeah, you could be crying for no reason, but there might be other things underneath that you haven't allowed yourself to acknowledge. So I invite you to really think about it. Is it your hormones? Yes, it may be, but it may be other things too. And they may be coming together in a whirlwind or a tornado for you that is just erupting at this time, because it is time for you to slow down and to acknowledge what you need at this stage of life may be different than what you needed before. Capacity changes over our life. So the things we used to be able to just run through and get done is very different for us in midlife. It really changes. And I really encourage people to work at a natural pace. So midlife is a wake-up call, and these mindfulness strategies and reducing self-blame are not just words on a slide. It's time for us to really think about mindfulness practices, daily practices, somatic work, even I put on the prescription for my patients yoga, meditation, walking, reflection, journaling, or prayer, whatever is appropriate for you that takes you back into yourself to think about. So that is really important, and I hope it answered that question that came in advance, at least at a general level. Seek evidence-based care, and if your symptoms are significant in that they are impacting your ability to function consistently, and you're feeling concerned that there may be other things going on, or you're just not getting better with some of the standard sleep, diet, exercise, mindfulness, stress management strategies that we've talked about several times, if you're just not getting better, that is when you seek medical care. We know that medical care will often focus on medical therapies. And so there are, and we've reviewed this previously, non-prescriptions, there's prescription non-hormonal, and there's prescription hormonal. The mainstay, the gold standard treatment, which is effective for most people, is prescription hormonal menopausal therapy that is going to help increase the estradiol levels, which are the declining estradiol levels are causing most of the hormone related symptoms. And so menopausal hormone therapy is really appropriate for most people. We know that only about 10% of the Canadian population that it would be appropriate for are receiving menopausal hormone therapy. And so I encourage people to have that conversation with their healthcare provider. Leadership considerations. So if you're in the military, you are a leader. In fact, if you're a woman, you're a leader of someone. If not just yourself, you're a leader of your family, your community. But if you're in the military, you are absolutely being called into leadership. And in whatever it is and whomever it is that you lead, it's important to consider using respectful, private check-ins for people who may be perimenopausal and menopausal, offering practical adjustments when feasible, avoiding stigma and jokes, and treat this like any other readiness factor. How would you manage someone who has a sprained ankle or another issue? You're going to be respectful. You're going to check in. You're going to figure out what adjustments may be needed. You're not going to joke about it. These are standard things that we just need to look at menopause in this environment and ensure operational readiness for the people that we lead. This is from the Menopause at Work in Canada report. And I thought these statistics were important to bring forward. 67% don't feel comfortable speaking to their supervisor. 70% don't feel comfortable talking to human resources. And 48% say they would be embarrassed to ask for support. That would make a difference for them. And not just for them, it's going to make a difference for their teams and for their operational readiness. So these are big numbers that our leadership needs to be aware of so that we can be forward thinking and open dialogue where necessary. Women report struggling in silence, being embarrassed, fearing repercussions, working to overcome perceived shortcomings. So working harder and not getting to where they wish they could, and dismissing the impact. So I think it's important to mention that, women will work harder in order to be able to achieve the same things and push through these menopausal symptoms, when in fact, if there were adjustments made or adaptations, they wouldn't have to be striving and pushing so hard, and they would get to the same or better productivity levels. And I think we're forgetting that. Women by nature are people who will just continue to push through and get things done at significant personal cost. More statistics from the Menopause Foundation of Canada. 87% of women agree that they need support throughout all stages. 75% agree that employers would benefit from offering these supports. And 77% agree that there should be more support in the workplace for menopause. So these are big numbers. These are what women are saying they want and need from their leadership. Let's talk about culture. So the tone starts at the top. The tone has to include men in the conversation. And from my experiences, men are more than willing to be having this conversation, often our greatest allies. We inviting men into this conversation and assuming the best of our men that are in leadership, that they really want to help and they really want to understand. As leaders, we need to listen, learn, provide support, consider what's going on in our workplace environment, what's happening with workplace health and wellness initiatives, and consider a menopause-friendly designation. So are you a company that's not just going to put this on a piece of paper, but actually operationalize it in your workplace? Consider hiring and retention policies. Do they have menopause considerations? Short and long-term absences, are there menopause considerations? Is there menopause training for managers and for employees so that the dialogue can be open in both ways? And some mental health initiatives that would be a good place to serve women who are feeling really overwhelmed, overburdened, and as we heard from one of our questions, really unable to manage the ups and downs that are happening. And in one of our previous webinars, we talked about the fact that menopause can either unmask mental health conditions, depression, anxiety, even ADHD, or menopause can exacerbate an underlying mental health condition. So it can make it worse. The menopause needs to be considered as part of that presentation. Being careful about myths and misinformation, ageism and menopausal humor, respecting people's personal boundaries. If someone's saying, I can't talk right now because maybe their hot flashes are really intense and they need to walk away, that's okay. We need to respect. I mean, we just do this for humanity. So we need to be cautious and careful and caring and compassionate with our menopausal population. And being confidential, not coming back into the meeting, Mary had to leave because she was having hot flashes. That's really embarrassing for women. And we've seen how dismissed and embarrassed women already are. The physical environment seems easy to fix, but we need to acknowledge first that we need better ventilation, air conditioning, access to washrooms, access to and discreet disposal of period products. So we know that perimenopause can come with some really intense fluctuations and menstrual bleeding and menstrual flooding. And we need to have the availability for women to be able to manage that. Access to cold and clean drinking water, blinds and window coverings so women aren't having to sit in the hot sun or the heat. And hours and shifts, so flexible, even hybrid or remote work, reducing travel if a woman is having specific symptoms that are not well managed, taking breaks. And we are the best people to know when we need a break. And so I always say to my team, take what you need. If you're, for example, on a Zoom call and you need to turn your camera off and go walk away for a minute, that's okay. We need to be really caring and compassionate for people about what they need. We know that we are human first. We have human physiologic needs. We have human moods. We have human emotion. And that is something that we can't eliminate, or we absolutely don't want to eliminate from the work environment. That's what makes us creative and innovative and collegial and collaborative. So we want to be doing everything we can to ensure we're helping women and men work to their fullest potential. Workload adjustments, alternate duties, stepping in for your colleagues if they ask. And how do we support each other? I put this as a whole separate section because whether you're an individual or whether you're a leader, whether you're in a workplace environment, if you work with even one other person, we need to be supporting each other. So understanding symptoms and people's lived experience. Really just understanding without judgment. I call this radical empathy, to be compassionate and empathetic toward another human being, whether it's menopause or something else, is vital to our shared humanity. To empathize, to ask and listen, respect personal boundaries, communicate, Be creating a safe environment where everyone feels comfortable. People feel that they often feel that they aren't meeting their own high standards, and so they're being really hard on themselves. And so giving people a little extra space and grace, especially high achievers. So we know in the military community, there are a lot of really high achievers. And for people who are always trying to move that bar for themselves in professional development and personal development, capacity changes over time during this menopause transition, during aging, but also just during life. Capacity waxes and wanes. All of us, men and women, have natural harmony and rhythms to we have circadian rhythms, we have weekly and monthly rhythms, men and women both. We have rhythms through time, through seasons. If you've ever felt like the energy of spring or the hibernation of winter, we have, as humans, this need to be cognizant and intentional and understand what it is that we ourselves need so that we can extend to others what they need as well. And so high achievers, I would just encourage you, again, working at a natural pace, understanding that this is a transition, that this is normal, that you are not alone, and that holding yourself to some insurmountable expectation is going to add stress. And again, as we learn, stress is going to make symptoms worse. And to provide practical support to your colleagues, offer help as challenges arise. Let's get into some military specific, in addition to all the other information we talked about, what could be military specific options? Temperature strategies for where work environments are, training adjustments, so normalizing performance protecting modifications is not weakness. So adjusting fitness modalities, adjusting workout regimes, adjusting schedules. This is going to be performance protecting, and it's not a weakness. Someone should never be made to feel that they're not doing good enough because they need something a little different than they needed before. Military women may be harder hit because of sleep disruption, shift work, operational tempo. Often that amplifies fatigue, mood impacts. We talked about how sleep just ripples into every other facet of life. Heat, kit, uniform constraints, that can intensify vasomotor symptoms and genital urinary symptoms. So urinary incontinence or genital urinary prolapse can be more prominent because of the weight that military women have to carry around and the training that they do. And so being considering this as a population health potential study, measure, or modality that has to be considered for military women, different from other populations. Injury risk and recovery capacity matter for training standards and long-term health, realizing that one injury can change an entire person's life and career. So we all know, a lot of us know, it takes at least 6 to 8 weeks to heal from a soft tissue or musculoskeletal injury, at least 6 to 8 weeks. That's a couple of months of not being able to do what that woman needs to do. And that could be career changing and is definitely life changing. And during that 6 to 8 weeks, that person may not be able to train. So there's the detraining effect that occurs as well. So we want to be preventing injury. We want to be protecting performance. And operational readiness is often required without notice. So military women are needing to be at the ready all the time. So some military solutions is to look at the goal is performance protection, which is not special treatment. Support is about safety, performance, and retaining the incredible talent that we have in the Canadian military. Menopause support is consistent with operational equity and readiness. Menopause support is not a nice to have, it is essential. So your Women in Diversity Health has this guide to menopause. So we're going to get into some resources, things that you can do and read and look into. Menopause and Diversity health guide to menopause. You can get there by going to canada.ca, searching for diversity, women in diversity health, or searching just for menopause. I tried it myself, and menopause information comes up quite readily. So there's some great and robust resources there. The other two webinars we've recorded are available. Other resources are coming your way as well on those websites. Please realize you are not alone. Menopause is not a weakness, a normal transition. Evidence shows that when symptoms are severe and unsupported, work outcomes change. I would even say career trajectories change. What I have not mentioned that I really mention in all of my talks is that women in this age range provide the wisdom, the experience, they provide the depth of a lot of our workforce. And that wisdom, that life experience, that professional experience is needed to mentor upcoming generations and upcoming people in our work systems. So supporting this generation of midlife, perimenopause, and menopausal women is essential, not just for those women and not just for the real-time operational objectives, but it's essential for the future of our workplace. So we want to be doing everything we can to support women in midlife and ensuring that they stay in the workforce in meaningful, purpose, heart-led ways. So in the Canadian Armed Forces, menopause can affect readiness, safety, retention, as we've seen, and support is a performance strategy. So you're not alone. This experience affects 50% of the population. Some breeze through, others have a really rough time. Symptoms are valid. 40% struggle at work. 7 years, up to 7-year duration, even up to 10 actually in my experience. Help is available. There's resources. Ask for accommodations. If you need medical treatment, you're just not getting better or finding what you need, medical treatment exists. Self-advocacy is vital because people are probably not going to offer you something unless you ask for it. Until we actually get some policy changes from the top down, people need to know their rights. Women need to ask for what they need. And I can assure you, in most situations, when a woman asks for something that she needs, it will be met with compassion in most of my experiences and situations. And if not, it's time to pull together some of your colleagues, some of your trusted leadership, and make sure that you continue to advocate. Don't be silenced. Peer support improves outcomes and reduces isolation. And of course, in the Canadian Armed Forces, there are a lot of community gatherings and different communities that you can ensure that you are a part of. When accessing care, if you need medical care, look for a provider that is a medical doctor, a nurse practitioner, a licensed healthcare practitioner, preferably with the Menopause Society certification. And that's listed as either MSCP, Menopause Society Certified Practitioner, or CMP, Certified Menopause Practitioner. Watch for red flags, something that's not Health Canada approved. If you're trying to go online and buy something, look for Canada approval. Something that's just for you, special treatment, is probably something you need to be wary of, because standard guideline-based menopausal care is available, and it is standardized, it is well studied, and it is very safe. So if someone's telling you, well, this is just for you because of something specific about you, you need to be thinking about, well, where is the guideline coming from? It doesn't mean that we don't need to know specific medical history about you and medications you've tried, etc. But there's something very different about doing something unique to you, or taking expensive salivary tests, or even expensive genetic tests, or specific monitoring of your hormone levels. These things are not normally reliable or well tested. I will mention at this point, hormone testing is not recommended to diagnose perimenopause and menopause. And the reason is, and we unpacked this in a previous webinar, the reason is because hormones fluctuate hour to hour, day to day. And to look at, for example, salivary hormones is just a snapshot in time, and it's not going to tell you about your physiology or your need for medications or your need for other guideline-based treatments. So we don't do hormone monitoring because it's not guideline-based and it's not necessary to monitor or to even diagnose perimenopause or menopause with expensive tests. Compounded medications are usually compounded in a pharmacy that are they are not Health Canada approved options, and pellet therapy can be very dangerous because it distributes hormones in a very, very high dose, and it's a little pellet that goes usually into the buttocks, and it secretes hormone for 4 to 6 to 8 to 12 weeks, depending on your pellet therapy. And once it's in, you can't get it out. And I've seen a lot of adverse effects related to that. So watch for those red flags. Start with your primary care provider, and you can look for providers through the Menopause Society, the Canadian Menopause Society, and virtual visits are becoming much more common, even virtual visits by licensed health professionals, by menopause certified professionals, and private options exist as well. And so thinking about if you're not getting access, you're not getting answers, there are private options. As long as you watch for those red flags and you know that that visit is a credible visit, that may be a good investment if you're not getting the access or answers that you need. So this is the Menopause Society. It's at menopause.org, and there are lots of education items on there. And then in Canada, there's the Canadian Menopause Society, the Society of Obstetricians and Gynecologists of Canada, the Menopause Foundation of Canada, and we worked through their Menopause and Work in Canada report today for some of those the data pieces. And I'm going to put on the next slide the QR codes for you to be able to connect to these really credible and important Canadian resources. The Menopause Society is American-based, but all the others are Canadian-based, and all on this slide are very credible resources for you to access additional information. And I'll leave that up, and I can go to a few of our questions that were put in advance. I just want to pause and see, Mylen, are there any questions you'd like me to answer in real time?
Yeah, we do have one question in the chat. So the comment starts with, thank you for your excellent presentation. Have you come across gastrointestinal issues as a symptoms of menopause? Is there literature supporting this? Symptoms overlap with those of cervical cancer and colon cancer, which may make discussion even scarier and anxiety inducing.
Okay, and that was all one question, just to be sure.
Yes.
Okay. So so I'll go sort of big picture. Gastrointestinal symptoms that's very broad. A couple of things that come to mind when I think of menopause and gastrointestinal symptoms is that there are hormone changes and our bowel responds to hormones. So for example, progesterone is a smooth muscle relaxant, and it will slow the intestines, and it can sometimes create a sense of bloating or if you remember when you were cycling and you had PMS, just to give people an example of something they may be able to relate to, when you had premenstrual syndrome, which is usually about the sort of week or so before your period started, you may have noticed bloating, you may have noticed constipation, you may have noticed being a bit more crampy. And then as your period came and that progesterone fell off, some people would have an increase in what's called prostaglandins. They'd end up with diarrhea, cramping, loose stools, and then they'd start to have their period. So it gives us really good evidence to know that the bowels are very hormonally sensitive. So related to perimenopause and menopause, I have heard the whole gamut of gastrointestinal symptoms from menopausal women, and that's going to be something related to what the hormones are doing. So bloating is very common, and that can be a factor because the estrogen is decreased. But also, I think when we're talking about gastrointestinal symptoms, we need to be very, very clear that our diet, our exercise, even our sleep and stress impact what is happening in our bowel. So when we talk about diet, we want to make sure that we're eating lots of fiber, getting at least 25 grams of fiber a day, lots of color on our plates, making sure that we are having a regular daily soft bowel movement. And if that's not the case, think about why. Make sure you're getting lots and lots of hydration. Exercise is going to move the bowel more. So if you've ever had a day where you've sat and done nothing all day, you realize your bowels just don't work so well. And then there's the gut microbiome. So that's a whole other topic, but making sure you're eating lots of roughage, even some fermented foods like yogurts or kombucha, kimchi, if you're into that. So fermented foods will also help the microbiome and ensure that the gut health is healthy, which impacts hormonal health. And then briefly, you said cervical cancer and colon cancer increases the fear. So if you've got new onset gastrointestinal symptoms that you don't know what they are, and you're actually worried about there being a cancer in your abdomen or pelvis, then that's something you absolutely need evaluation for. And that can be evaluated and ultimately ruled out, which is the good thing. So colon cancer screening is really vital for women as they hit 50 to have had colon cancer screening. Cervical cancer screening needs to be done all the way from the age of 21 throughout the entire reproductive years for women. So cervical cancer screening is also really important.
Thank you so much. We also have a question about PCOS and how you verify that you're menopause and not just having amenorrhea from the PCOS.
Yeah, so that is such a great question. We get that question a lot, and I'm going to unpack that a few times here. But I want to start with saying that polycystic ovarian syndrome, or PCOS, is a gynecologic or medical diagnosis that happens for women in their reproductive years, so prior to menopause. It's a clinical diagnosis. So women have clinical symptoms of acne, hirsutism, which is extra sort of black hairs on the chest and abdomen, the chin. It also has a tendency to be overweight because of the hormone imbalance, irregular menstrual cycles, and sometimes infertility because of the lack of ovulation of the ovaries. So that's PCOS. But PCOS also has long-term chronic health implications, such as high blood pressure, high cholesterol, heart disease, and endometrial cancer if it's not properly managed. And so people who have PCOS need to understand those longer term implications, because they're going to have PCOS for potentially it's something that can go away but often doesn't go away. But you may have PCOS throughout your perimenopause and menopause time frame, and have to be considering those chronic comorbidities such as high blood pressure, heart disease, even diabetic risk, high cholesterol. Those all are a little bit higher for people who have PCOS and need to be considered for all people who are perimenopause and menopause, but more so for PCOS. PCOS tends to delay the onset of perimenopause and menopause, but it's confusing. But if you have PCOS and you have it well treated in your reproductive time frame, then it should be clearer for you as you enter perimenopause and menopause what's different from your PCOS. Now, if the question is, how do I diagnose perimenopause and menopause if I already have irregular cycles? I would propose that if you have irregular cycles with PCOS, you need the PCOS evaluated, because you should be getting essentially treatment for the PCOS. And then that treatment involves ovulation suppression and hormonal balance. And so if you have that hormone balance because of the PCOS and you head into perimenopause and menopause, then you have the hormone balance in perimenopause and menopause as well. So there's different ways to balance hormones in PCOS. they're very similar to the ways we balance hormones in perimenopause and menopause, but ultimately all of them are related to hormone imbalance. And I think it's just the kind of closing statement on that is if PCOS is contributing to symptoms that you don't understand or that feel confusing or seem to be getting worse, you need your PCOS evaluated or re-evaluated.
Thank you. We also have two questions that are about testosterone supplementation. I know we touched on it last time, but would you want to talk to it a little bit more again? How these two comments are questioning, like why doctors are hesitant to prescribe it, benefits slash issues of the different types of testosterone prescriptions.
Yeah. Sounds good. There are no Health Canada approved options for testosterone. So that's first thing. Off-label use, we use transdermal testosterone in male dosages that are adjusted to female physiology. So transdermal testosterone usually comes in a little packet, and if it's needed, and I'll get to that in a minute, it's prescribed at about 1/10 of a packet for a woman because she needs 1/10 of the dose. And so, what we know from studies, really good studies, and they're continuing to emerge, testosterone is indicated for women who have decreased libido or hypoactive sexual desire disorder that is causing a lot of trouble. Not just, I don't feel like having sex, which we have talked about, and you can find that on other webinars, but not just I don't feel like having sex, but it's impacting quality of life to such a detrimental effect that it's worth the risk of taking a medicine such as testosterone. And when we give testosterone in those cases where we've diagnosed hypoactive sexual desire disorder, we give it to the female physiologic range. So we want to be sure. And in those situations, the reason that not a lot of women will start on it or want to stay on it, in my practical and practice experience, is because it needs serial monitoring. It will increase cholesterol. We need to monitor lipid levels. We need to monitor liver because it can often impact the liver. And we need to monitor the testosterone level in the serum by a couple different measures because we don't want that testosterone to go beyond the female physiologic range or into the male range because we see a lot of adverse effects that come from that, and those adverse effects are irreversible. So deepening of the voice, extra hair growth, even clitoromegaly where the clitoris starts to grow, endometrial cancer. I've seen all of these in my practice related to too much testosterone that people were getting from usually from pellet therapy or from some of these clinics online where they just get testosterone and they aren't actually being properly cared for. And then there's also, I think, what this person or lots of people want to know is, well, can I take testosterone to help with muscle, with my muscle growth, with my lean muscle, to help with weight loss, to help with my mood, to help with my energy? I get those questions a lot, and the science is very clear. When we replace testosterone in the female physiologic range, which is the only place that is safe to do so, it doesn't have a significant benefit in any of those other areas. So we use it for a specific population only because the evidence has not panned out to show us that testosterone is a catch-all and great for everything. And I do want to also say that in perimenopause and menopause, ovaries continue to produce testosterone. The vast majority of testosterone is from the adrenal glands. And so for women who are feeling like, I want to optimize my hormones, including my testosterone, I recommend diet, exercise, sleep, stress management, all the things that are going to get your organs working as a symphony to give you the hormones that your body's producing and needs. And testosterone is not the magic cure for a lot of things that people are starting to hear about.
Yeah, thank you so much for that clarification. Going back to more menopause in the workplace, we have another comment here.
Mhm.
As a manager looking to accommodate employees with menopause related issues, I benefit from clear medical notes highlighting the needed accommodations. So without needing the diagnostic necessarily. Are there any tools to guide doctors or clients to help document uh, the needed recommended accommodations? And many employees don't necessarily have a supportive doctor, and perhaps maybe you could also comment on how managers can support that environment.
Yeah, so just to be clear, this is a manager looking for like actual tools and resources to be able to kind of have a listing of what those accommodations would need to be. I would start with the Menopause Foundation of Canada because they have work they have resources for leaders, for organizational leaders, and they have resources for women as well. And so there you will find potentially a listing of accommodations. I think based on the resources that I brought into this presentation, going back through this presentation, some of the slides were pretty clear about what women are saying they need. And those things were unpacked in terms of physical work environment, in terms of culture change, in terms of policy change, in terms of hours of work and flexibility around work environments. And so hopefully there's been a lot of resources unpacked here as well. And then I would encourage leaders to go to their leadership, because if leaders are asking that question and there's any other leadership in their organization, do it together. Come together as an organization to determine what not just one section of the organization wants and needs, but what the entire organization would like to understand and bring forward. Because, of course, that's organization specific, and certain accommodations can be easily implemented versus other accommodations need actual policy change.
Mhm.
Yeah, just make sure I answered the whole of that question.
Yes, and I think you pointed out in your answer and in your presentation how accommodations are not necessarily related to the medical needs, but more the environment needs, right? That can be changed without needing a medical note or a mention of it is because of menopause, but it could be because of discomfort, right? Related to menopause, so without having to go into those details.
Yeah, exactly. And to open dialogue, I think the key here is that managers acknowledge that we're human and that our human capacity is not a machine. And so whatever it is that's happening in our lives, maybe we were up all night with a baby breastfeeding. That's not a perimenopause or menopause issue, but it's a human thing that many people go through. Maybe we sprained an ankle, like I said. These are things that are human and require empathy and compassion. And menopause is really no different, except that it'll happen to a much larger portion, or at least 50% of the population. And that demographic of our workforce is so vital to the future of the workforce because of the wisdom and experience and all the things we talked about. I have a couple of other pre-submitted questions too, unless you have more real time.
We have one more. Can someone with endometriosis or adenomyosis use HRT?
Yeah, good question. So endometriosis is implants of the endometrium on other organs or areas in the pelvis, and adenomyosis are those implants in the muscle of the uterus. So they cause cramping and cyclic symptoms related to the cycling of those implants. So much like you get a period, those implants will cause problems where they are located because they're from the endometrium and they cycle just like the endometrium does. The endometrium being, of course, that lining that sheds every month. And with endometriosis and adenomyosis, normally ovulation suppression is going to be the best way to go for someone who's in perimenopause and still cycling and still having endometriotic pain. Ovulation suppression mostly with a birth control pill, either a progesterone only like Slind or an estrogen progesterone birth control pill, but something to create ovulation suppression. But when you get to perimenopause and menopause, it is those cycling symptoms should lessen. And the question being, is menopausal hormone therapy okay? It absolutely is. It's about 1/10 of the dose of a birth control pill, and a birth control pill is used to treat endometriosis and adenomyosis. And so menopausal hormone therapy is in such small doses that it can absolutely be used to treat menopausal symptoms. And then dosing and the addition of a specific progesterone needs to be considered based on whether symptoms are better or worse with the endometriosis or adenomyosis, but it's not a contraindication.
Thank you very much.
Yeah.
It is now 1 o'clock already, so thank you everyone for joining us today. And again, a big thank you, Dr. Hansen, for this excellent presentation and sharing your knowledge with us.
Wonderful. So wonderful to be here. Such an exceptional group of people. Thank you to our Canadian Armed Forces. Thank you to Mylène, to Nadia, and of course to Anna for putting on this beautiful three-part webinar series. And I look forward to being together again and spreading this excellent information for people so they can live their best.